if you have the time. Okay. Okay. So I'll just introduce. Okay. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. Welcome to our guest lectures for the day. We have two international experts with us, Dr. Linda Dimitropoulos, I hope I pronounced that correctly, okay, and Dr. Michael Trisolini. Both of them are from RTI, which is standing for Research Triangle Institute. For those of you who are not familiar, RTI is one of the world's largest research institute. It has over 3,700 staff, I think, on the website, working in over 75 countries, including Indonesia for many years. Okay? So it's a quite prominent institute. Please have a look at it at the website if you're not familiar with them. And for this particular guest lectures, we have Linda and Michael. Linda is from the, I have to read this so that I read correctly, the director for the Center for the Advancement of Health IT, Information Technology. But interestingly enough, her background is actually sociology. So it's actually a sociology of IT, something like that. So something which is very interesting and unique. So you'll hear a quite fresh perspective coming up from Linda. And so she will deliver the first lecture, which is, as you see here, using information and technology to address common challenges in public health. And then she will speak for about 45 minutes, including discussions. And afterward, Mike will come in with his presentations. Okay? So, Linda, floor is yours.
Great. Thank you. Thank you very much. And thank you all for coming today. I really appreciate the invitation to be able to come and speak with all of you. Sorry, I'm not really good at juggling a lot of tools, but my discussion today is going to focus on how we can use information science and information and communication technologies to build capacity in public health, and talk a little bit about the range of work that we do in our center, and perhaps convince you of how multidisciplinary our approaches are and why multidisciplinary approaches are needed. And I also want to talk a little bit about sort of the importance of the time we're living in and the wealth of information that we have available to us, and sort of some of the amazing things that we're able to be, that we're able to do with that information. This one? Oh. Okay, we need to learn to use the technology first. So in my center, our focus is on advancing the use of health information to inform decision-making in a range of areas involving healthcare. So decision-making for service delivery, decision-making for population health management, decision-making for public health. As I said, it's a very multidisciplinary area of work, and our center has about 30 informaticists, researchers, policy analysts, clinicians, all working together to try and solve the issue of how we insert technology into the healthcare system and how we do it safely and effectively. We work very closely with about 40 plus other researchers at RTI. So the 30 folks that we have in our group work very closely with folks in Dr. Trisolini's group, and in many of the other groups you see here on this slide. Okay, so as I mentioned, our focus in the center is on research and technical services that help to advance the use of health information. Most of our work is with the federal government in the United States, but much of it and growing is with international organizations. So we work in four main areas, or I like to think of them as levels. So we work at the sort of national level, the enterprise level, doing work around policy for health IT implementation. We work in data and standards, data standards and interoperability standards for widespread exchange of health information. We also work, as I mentioned, in public health. So public health informatics to improve public health capacity. Sorry, can't adjust this very well. We also are working at the provider or practice level to help improve adoption of technologies like electronic health records in order to collect the data that's needed to inform all these other areas. And then finally, we work at the patient level. So we're using technology to enable behavior change. So we use personal health records, we use text messaging, social media, self-tracking devices like Fitbits and other tools that are used to track health information. This is an overview of the U.S. federal government plan for implementing health IT nationwide. And I just wanted to give you a sense of the breadth and number of programs that are happening in the U.S. right now. About 3 years ago, the government invested $50 billion in trying to advance the use of health information technology to collect information, store it, and then effectively use it for other purposes like quality improvement. We set up programs that are to incentivize doctors to adopt technologies. So if doctors will invest in the systems, which there's a lot of pushback from doctors because systems aren't very usable and they're very expensive. So there are incentives provided for primary care doctors and hospitals to invest in the technology. Then there are some regional extension center programs that provide technical assistance to help doctors to implement the technology in a useful way. There's also certification programs that are targeted at the developers of technology so that the technology provides the functionality needed to achieve the goals of the program. There's also a workforce development program that instituted nationwide programs in colleges to help develop the workforce to support health IT. There was a lot of money invested in the states. In the United States, the state level governments and the federal government work hand in hand sometimes, but the federal government incentivized the states to work on health information exchange practices. We have a very decentralized system, much like Indonesia, in that the states have a lot of power and the local jurisdictions really control healthcare and healthcare licensure. And so the policies and the regulations around healthcare delivery really reside at the state level and the federal level. So the federal government incentivized the states to try and move this program along. There's also programs in standards and interoperability. There's a framework being developed that's being implemented across the country. And then there's a certification program, which I mentioned, and then the privacy and security framework. And as mentioned earlier, I'm a social psychologist, and most of my work is on the policy side, and I do a great deal of work in the privacy and security area. So the primary theme of my discussion today is how we can use information science and technology to address common challenges in building capacity in public health. And I love this quote: public health is negative. When it's at its best, nothing happens. There are no epidemics, food and water are safe to consume. So just to give you a sense of what the U.S. public health system looks like, we have over 3,000 county and city public health organizations. We have 59 state territorial organizations. The federal government has multiple areas that focus on public health. We have the tribal health agencies, more than 160,000 public and private laboratories, multiple hospitals. It's a vast system, and it's not very well connected or integrated, and many times it's not very well funded at the local levels. But one thing all these organizations share is really a common goal, and that is if they have timely, accurate, and cost-effective information, that is, if we can capture, share, analyze, and respond to it, then they're better able to do their jobs. but their needs are funding, staffing, infrastructure, practice, and then the legal and policy wraparounds. I'm going to talk a little bit about infrastructure first, and then I'm going to talk a little bit later about practice. I'd like to just show you a clip that gives you an overview of one project that we've developed at RTI with funding from the Centers for Disease Control and Prevention. The BioSense program is an all-hazard biosurveillance program that we have been working on. I want to show you a little bit of an overview, and then I'll talk about it a little more. Okay, so the BioSense video worked this morning in my slide deck, and it doesn't work here, I guess. So I apologize for that. So the BioSense program is, as I said, it's an all-hazard biosurveillance program that is built with funding from the CDC. And basically, it's a common, low-cost infrastructure. It's a web-based infrastructure that's used to collect information from the public health organizations from across the country, compile it and display it so that we can track in real time various diseases and hazards that come up. It's a fairly new program. It was implemented originally back in 2002, and BioSense 1 wasn't very successful. And the reason why is that the CDC tried a very top-down approach. They tried to put the program in place and then, sort of mandate that the public health organizations participate. The problem was that many of the local public health jurisdictions didn't have the capacity to participate. They didn't have their data in electronic format. They didn't understand the need for the CDC to mandate their data. And while they do have regulations about reportable illnesses and immunizations and so forth, this was an extra mandate on top that was not funded, and because it was top-down, there was a lot of pushback and very low participation. What RTI did with the CDC was take a different approach. We took a user-centered design approach. We worked with the various jurisdictions, and we asked them, if you were to participate in the biosurveillance program, how would you like to participate? What would be helpful to you? And so then we took all that information and we built a program. We redesigned BioSense to be a more user-friendly program for the jurisdictions. One of the interesting things about BioSense is that it provides basically a catcher's mitt, so all the jurisdictions can submit their data in whatever format they have it, and the catcher's mitt will grab it. It's cloud-based. This is the first U.S. Project that is cloud-based. They've been reluctant so far, so this is a kind of a new effort. And so the BioSense system can accept the data in any format. It's grabbed in the catcher's mitt, and then it's all converted, standardized, and all the organizations can run reports off of the data. They can see other data. The CDC has an agreement with all the organizations that they share the data, but the CDC does not get access beyond what is uploaded. All the jurisdictions sign a data use agreement with the CDC, so the terms are really based on the local level, and that made it palatable to the jurisdictions to participate. So this will give you a sense of what the data visualization tools can provide. The screenshot from BioSense here shows on the top, you can see the kind of what and the when. This is influenza-like illness from 2012. And the top shows you the percent of total visits over time. The bottom part of the screen shows you the where and the when. So you can see that the darker colored states have a higher incidence rate, and it's shaded accordingly. So we've used BioSense in many ways, obviously to track H1N1 back in 2009, but we used it to track iodine exposures following the. Great, thank you. Great. Oh, that is much better. Thank you. So in 2011, we used BioSense data to track radio activity exposures among our military in the area because the Veterans Affairs and the Department of Defense also upload their data into BioSense. So we had real good way to kind of track exposures after the nuclear disaster in Fukushima. We have also used it to track heat-related illnesses in Texas we've had some really unseasonably hot weather over the past couple of years, so we've used BioSense to track heat-related illness. In 2010, we used it to track dengue fever surveillance in Florida. We also were able to do some tracking after the Deepwater Horizon oil spill in the Gulf of Mexico. And of course, as I said, in 2009, the H1N1 flu pandemic. So I want to talk a little bit about practice. One of the challenges we have when we have such a distributed public health system is that we've got many different organizations developing practices, and there's no mechanism for sharing information. So we have a lot of redundancy in the system, and as I mentioned, we have sort of underfunded programs at the local, the county levels, sometimes at the state levels. And so they really need a way to better share information, because many of the jurisdictions develop excellent programs for smoking cessation or immunization programs, or developing tools like online appointment scheduling kinds of tools. So what we did with the help of the Robert Wood Johnson Foundation is we developed a public health quality improvement exchange. And what this does is it really creates a shared infrastructure for public health organizations to upload, input their programs and their quality improvement practices to share with others. And then it provides a resource for other organizations to go in and perhaps, get an idea. If they're looking for smoking cessation programs, then they can search and they can find other programs to build off of. And they don't have to kind of reinvent the wheel. And it really does have an impact on these kind of under-resourced organizations. Basically, when an organization wants to submit a quality improvement practice, it does go through more or less a peer review for the quality and effectiveness of the program. So everything that gets submitted doesn't get put on. But what they try to do is to provide enough feedback for the program to get it developed enough so that it becomes something that's very useful, very applicable to other organizations. So the outcome of the process is to be one that's very proactive in terms of helping to develop a quality improvement practice rather than to just kind of shut it down and reject it. So it's one of acceptance and approval, but it's a very rigorous review process. So the website, and you can go to it when you have time. It's very cool. And so you can either browse all of the submissions in a general sort of way, or you can drill down and browse by key categories. And you can also drill further once you go into one of those categories and see the specific programs that you might be interested in adopting. And I would suggest that these are many of them are very applicable because globally we share a lot of common public health issues and challenges. And so many of the programs I would think could be adapted for other uses in other countries. There's also another feature, it's called Ask an Expert. And so if you browse through and you don't find a solution, you don't find an answer, you can actually submit a question. And there's a panel of public health experts who daily pull in these questions, discuss, and send back responses and try to be very proactive in connecting you with an answer or connecting you with someone who knows an answer to a specific challenge. So it's a fairly unique feature of the program in that it has this interactive component. It's not just a knowledge repository. So I think one of the things we really do appreciate about this PHKICS program is that you have one person looking for an issue, and then you have many people who can provide an answer for you. So it really does a great job of connecting up and sharing resources across the country. And it's a very simple technology to actually apply to a pretty serious challenge that we have. So I just want to give you a quick summary. I think that we all share common goals with respect to public health challenges. And we all share common needs to be effective and comprehensive, to have an effective and comprehensive public health infrastructure. And I think that applying information science and technologies can help strengthen the infrastructure. And then sharing proven methods for quality improvement practices in public health really benefits everyone. And I do want to just acknowledge my colleagues who do the heavy lifting on these projects. Thank you. And I think we can open for a few questions.